My original motivation for looking at the screening was the UDS measures for 2012. As a community health center, every year we have to report our UDS measures. And so that's something that as the CMO, we follow very carefully, and I'm very concerned about how our health center is performing on those measures. So in 2012 was the first year that colorectal cancer was added to the UDS measure. And so I was just concerned about how our clinic had performed for that year. So when I first realized that our results were 3%, I didn't believe it. I thought it wasn't true. There's no way we could have a rate that low. Because I could think of personally about a dozen of patients or more that I had discussions with as far as colorectal cancer screening, and I know we had ordered it. I know the patients had gone for the test, and so I just couldn't understand why the results were that low. We had also just started an electronic health record, and so we were testing out our population health analytic. And so I just thought that maybe there's a problem with the results. Maybe just wasn't recording accurately. But when I went back and audited the chart and found that although we did talk to patients about colorectal cancer screening, the results weren't in the chart. And it's one of the things that was a valuable lesson that I learned that seemed to be very common for health centers when they are first adopting an electronic health record, is understanding what gets measured and how it gets measured. So for us, although the order was in the chart, discussion was made, in our record it was put in more as a free text. So I kind of typed in that the patient had gone for the procedure, but we didn't have the results back in the chart. And it wasn't until the results were back in the chart in a structured field that we got credit for the report. So when it came to my role as a provider, of course as the medical director, I was concerned that our results were low. And so I wanted to identify why our results were so low, and then come up with a strategy that could be developed in partnership with our providers on how we could improve it. So I did know it was my responsibility to identify why the results were low, but I also knew that in order for us to have a solution, I needed the provider's input and support in moving forward. So once I identified it was important that we focus on colorectal cancer screening, the first thing I needed was a quality improvement director. At the time, about 80% of my time was spent in clinical practice, and so I needed someone who could be dedicated or devoted to running reports, analyzing those reports, and then giving us feedback in real time on our performance. Many times, practices aren't successful because providers themselves aren't thinking population-based. They're thinking about their own panel or their own specific patients. But in order to have success for your clinic, you have to think population-based. So someone has to be thinking about all of the patients in the practice, and not just Dr. Winfrey's patients, or not just Dr. Smith's patients. You need to have a population approach. And I think some plans may fail because they leave it up to individual providers to come up with a strategy for their patients. And their strategy may not be broad enough for the population. And so most providers are always thinking colonoscopy, because they know that one, once the colonoscopy is satisfied, it's satisfied for 10 years. Two, there's nothing that's better than a direct visualization inside the colon. You can look inside the colon, you can see polyps, you can see cancers, and not only can you see them, if it's a polyp, you can remove them at the same time. And so, because you can actually have prevention at the same time that you have in the screening done, most providers will always steer toward colonoscopy because they know that you can not only screen, but you can prevent at the same time. But it's also important to realize that just a colonoscopy-based approach is not going to reach your population, and it's going to always keep the numbers low, unless you're part of a system that has access to colonoscopies that's readily available, and you have a population that's already primed and ready to undergo colonoscopy screening. There's studies that show that some patients just aren't ready for colonoscopy. No matter how much you convince them or talk to them about it, they just aren't ready. So for those individuals, you still have to offer them an option or a choice. But when it comes to the individual physician, in their mind, they're going to always push for colonoscopy because they feel like it's going to be the best for that patient. The way you get them to think broadly is you have to have them think about their population as a whole. Dr. Smith, how many patients do you have that are 45 and older that need to be screened? If it's 500 patients, even though you may have 20 that you know can get a colonoscopy, what about the other 480 patients? You can't just ignore them. And you can't just say, well, I had the discussion, they're not ready now, we'll discuss it again next year. They're still not satisfied, right? And so having a population-based approach says, okay, although these 20 patients are ready to get screened, let's offer stool-based tests or other options to these other patients that may not be ready for colonoscopy now. And then when they are ready, let's go ahead and get them that colonoscopy. And so it's very, very important for the clinic or whatever health system to take a population approach to it. And so you need a CMO or a quality improvement director to really invest time in identifying that strategy and then discussing that strategy with all the players involved so that they understand this is how we're going to address it for all of our population and not just for your panel. Once I had that information, then I could sit down and develop a strategy. So I needed a QI director full-time that could run data and do some quality improvement analysis for us. And then I also felt like I needed a dedicated office personnel, like a medical assistant or someone else who could be committed to educating patients on the importance of colorectal cancer screening, as well as reminding patients of when it was time for them to come in for their appointment and when they should bring their test back in. So those are the two essential members of the team I felt we needed, a QI director and a dedicated office personnel who could educate patients and follow up on testing.